So with the last few minutes, I'm going to talk about the second indication for local therapy, oligoprogression. Again, the notion behind this timing of treatment is patients have been doing well on an immunotherapy chemo combination or immunotherapy combination or a TKI for months, if not years. And all of a sudden, there's one or two sites that are progressing on imaging. And quite honestly, the medical oncologist is saying, hey, the drugs are working really well in 99% of spots in your body. How can we, prevent? How can we keep the patient on the same drug, but overcome some of this resistance? And one of the ways that we can do it is with radiation. And so this is what's a little bit, troubling. Is that we still to this day believe, and this is an old slide, but we still believe that the number of patients or the percentage of patients that durably respond to immunotherapy, for instance, is only 1 in 3 lung cancer patients. And it's really 1 in 3 of most types of cancer patients. And then the other thing that we found that's highly troubling is that if you take the 4 patients with the same EGFR mutation, for instance, here, exon 19 E74, 6, and you give them osimertinib, you get a vastly different outcome. Some patients progress quickly, some respond enormously well, others respond in a mediocre fashion, and we still don't understand how or why these patients are responding so differently to the same drug with the same mutation driving their tumor. I think it has to do with how that patient's immune system reacts to the tumor, how the immune system reacts to the tumor plus EGFR mutation, what co-occurring mutations that tumor may have that may predispose one patient to behave really well, such as patient 3 on the left, and the other patient 1 to progress so rapidly. And so these are the things that we're trying to learn with some of our trials. But we did a trial a number of years ago, 2014, where we just did a single arm phase 2 study where we basically took patients with non-small cell lung cancer who had progressed on multiple courses of systemic therapy, but not to too many sites, what we call oligoprogression, limited number of progressive sites. And what we did is we radiated all of those sites, and then we saw how these patients did. And the numbers here may not impress you, but remember, this was an era preceding immunotherapy, it was an era preceding targeted therapy, really. And these patients were only receiving cytotoxic chemotherapy. They'd failed 1, 2, or even 3 courses of systemic therapy or lines of systemic therapy. And with us radiating the residual disease that was progressing, we got a progression-free survival interval of 14.7 months for these patients, and we allowed them to live for almost 2 years despite terrible prognoses. So this suggested that this idea of treating when patients are progressing in a limited fashion with radiation to eradicate resistant clones may be the way to go. And so subsequent to our work, which kind of drove this field, Jillian Tsai at Memorial Sloan Kettering did a randomized study. So she basically took non-small cell lung cancer patients and breast cancer patients that had metastatic disease, and then on systemic therapy, they had limited progression, sites of progression. She gave radiation to those limited sites, and she asked the question, did the radiation improve progression-free survival outcomes for these patients? And indeed, the progression-free survival and even the progression-free survival improved for the lung cancer patients that were metastatic. Unfortunately, did not offer any benefit for the breast cancer patients that were metastatic. So clearly, another piece of evidence that lung cancer patients continue to benefit from radiation, but we have to find and optimize the patients that will benefit from this most optimally. So my team here did a consensus guidelines, by the way, of how to manage patients with metastatic disease from a local therapy standpoint. And really, as you can tell, the field is shifting and changing very rapidly. But 3 things are a must that you should take from this consensus guidelines. Number 1, patient input is a must. it's really the direction we go, the aggressiveness that we do, that we use in terms of treatment selection really should be driven by what patients desire, what their goals are in life. Number two, it should be driven by a multidisciplinary discussion of, again, thoracic radiation oncologists, medical oncologists, surgeons, pulmonologists, pathologists, radiologists, palliative care people, etc. And then the last thing we would always say is do not underestimate the toxicity associated with these treatments. So, final take home messages of our presentation today. Local consolidative therapy, i.e., radiation and or surgery, after the patients have received some induction systemic therapy for stage 4 non-small cell lung cancer is not for all patients. However, we could still probably identify patients who will still benefit from local therapy or salvage therapy for oligoprogressive disease based on multidisciplinary discussions. Toxicity is critical to review and minimize. And I think the more we do to minimize these toxicities, the more we can translate the benefits of radiation to a PFS or OS benefit. But ultimately, we need better biomarkers to predict the trajectory of every individual patient's metastatic disease as a means of optimizing their outcomes. And then once we have those biomarkers, we can really enrich future trials and future standards of care with the right treatment for the right patient population. And we will always then hopefully see a benefit for our patients with respect to survival outcomes as well as quality of life. And with that, I thank you for giving me the opportunity to talk to you about this topic that's near and dear to my heart, and I would imagine would be near and dear to the hearts of all advanced lung cancer patients and their family members. Thank you very much.